arm. So unlike the acetabulum of your hip, your socket for your glenoid is very small, and then it's built up by ligaments that are attached to your acromion and clavicle, and on your coracoid as well, but that's more anterior. I can't draw that here. And then you have the head of your humerus, which then houses the rotator cuff muscles. So you have your supraspinatus, your teres minor, and your infraspinatus, and then your subscapularis. So all this is the rotator cuff, but you could see that the supraspinatus is the most vulnerable of all of them. So unfortunately, the muscles that protect the rotator cuff are the rotator cuff muscles. So in order to protect them, they need to be working properly. But when they get damaged from repetitive impingement against the acromioclavicular joint, they don't work properly, and so it's a double-edged sword where it gets more impinged and more impinged. The patient has pain, they move less, they get tighter, and then they impinge even further. So it's a really a cyclical pattern that it's hard to break the patients away from, because unfortunately it's exercise is the only conservative way to fix that. And so if their rotator cuff muscle is torn, it's probably not torn all the way through. So it's not a full thickness tear that needs to be repaired. Your body can repair this if you stop pinching it. And you can live with some degree of a tear that, you know, maybe your body can't fix it all the way, but you can still function perfectly fine with that. And actually there are fabulous exercises that we won't learn, but that even someone with a full thickness tear can function pain-free, but those are people who are unable to undergo surgery for other health reasons. The acromion is a big culprit in the tear, not only because of its superior position between the rotator cuff muscles and the head of the humerus, but also because it gets a hook on it. Some people actually have a more hooked acromion, and that's normal, but then it gets osteophytes and arthritis, and it becomes even more of a danger to your supraspinatus and the other rotator cuff muscles. So you can actually strengthen the rotator cuff to pull down and protect itself from even a bit of arthritis or a hook of the acromion. But there are certainly patients who need to have surgery to get rid of some of that, and that's called an acromioplasty. And then they may need repair of the tendon, but oftentimes patients who really didn't give therapy a try don't even have a stage 2 rotator cuff tear, but they just think having surgery is easier. And unfortunately, the rehab, unless you have only an acromioplasty, the rehab is unbelievable. So I would say to undergo therapy prior to your surgery is really the best way to go. And if a patient has therapy and it's ineffective in relieving their pain, they are still better off having gone through the exercises preparing them for surgery. And especially a patient with lack of motion before surgery, and then you give them surgery which immobilizes them for, well, very protected for 6 weeks. They're going to have a lot of trouble regaining that motion. So the initial phases, we don't want to enact the rotator cuff muscles when we're initiating the beginning of therapy. We want to rest them. Oftentimes I'll tape the patient's shoulder so that they're not just getting the weight of their humerus pulling on their, usually, like I said, the supraspinatus muscle. And so if a patient has pain sitting all the time, I'm going to tape their shoulder. I keep hiking my shoulder, so I don't want to use the upper traps. That's something we'll learn in the treatment. But we want to hold that humerus up just to let the pressure on the attachment, let me see. So this is a supraspinatus muscle tendon, and it's going to be attached to the head of the humerus. And so it's going to be attached to the humeral head, and so the weight of the humerus is going to be pulling on that. And so if I tape this up, it'll just support it and take some of the weight off. So that's what I do in very inflamed cases. And then we also have the patient icing and taking non-steroidal anti-inflammatories. Not that we're prescribing that, but if they say, oh, I'm telling them to ice it, and I encourage them to take their non-steroidal anti-inflammatories. I may tape them. I don't tape everyone, only the ones who have pain in sitting. I encourage them to sit with a pillow. Here's my eraser. Sit with a pillow to keep their arm from internally rotating and adducting, because that puts stress and decreases the blood flow to the supraspinatus. And we want to increase that blood flow, and if you increase the blood flow, it's going to heal faster and more appropriately. So other things that we can do in the first stages is to do some pendulum. So we learned pendulum exercises for the fractured humerus. So you're going to do pendulum exercises or self-passive range of motion exercises. So you want it to be passive or even active assisted with the cane or the wand, which is what we did also with the humeral fractures. And that's because I don't want to engage the rotator cuff. So the patient's in supine and they're using their cane or wand or even a towel to help elevate their shoulder, and because the scapula is supported from the supine position, their arm weighs less. They're going to engage the rotator cuff much less or possibly not at all. And that's why we're doing the pendulum and the self-passive. So self-passive, they're going to slide across the table, slide or walk up the wall and try to get their arm stretched without using the muscles as much as possible.